YWCA USA's annual Stand Against Racism campaign. And this year's focus, which is very relevant for the times, is on racism as a public health issue. So we know that structural racism does play a role in determining the conditions in which people are born, how they grow, work, live, and age, and that these factors do affect people's access to quality housing, education, food, transportation, political power, and many of the other social determinants of health. So we on the Young Women's Leadership Council are very excited to be holding this conversation today to talk about kind of the state of our nation right now. We've seen the disproportionate impact of this pandemic on Black and Brown communities. We understand how important it is to talk about equity and to talk about racial equity, particularly within the healthcare industry. And so we brought two great speakers to talk about this from two different vantage points. This conversation is for you. So Dazon, Darby, myself, and a few others work in the healthcare industry, but we want to know what questions you have if you're trying to kind of talk to your peers or friends or family about why this is such an important issue and bring them along. Before I get into introductions for Darby and Dazon, I want to ask all of you who've joined us to introduce yourself in the chat. Let us know what brought you here, and also tell us what you hope to gain from today's conversation, because we would want to tailor what we'll discuss to what some of your questions might be. So I'll give everyone a few minutes to chat in what's your name, what brought you here, and what you hope to gain.
Hi, everybody. My name is Sambo, part of the council. I just hope to gain to hear more about just a lot has happened this week in regards to racism and just what has the verdict and everything. We got a guilty verdict, but it wasn't really, didn't sit well with everybody, which is like, okay, it took them this long to decide on something that everybody knew a year ago. So just trying to get some comfort out of that.
Thanks, Sambo, for sharing aloud. Others, if you want to share in the chat what you're hoping to gain from the conversation, or if anyone else is so moved to share with the group, you could do so. Okay, thank you for those of you who shared what brought you here tonight. I will now introduce some of our panelists. So, and you can continue to chat in if you have other questions or things that you want to get out of the conversation. So Dazon Dixon Diallo is a Georgia-born public health activist and scholar. She founded Sister Love, which is a women's HIV, AIDS, and reproductive justice organization in Atlanta and also in South Africa. And Darby Sullivan is a researcher with a best practice research firm in the DMV area. She serves as a thought partner to health system leaders to meet their strategic goals with actionable and sustainable solutions. Her areas of focus include population health, including the social determinants of health, managing chronic conditions, and supporting patient engagement. So I'm going to actually turn it over to Ondine to recognize someone else who joined today's conversation.
Hello, you all. I'm Ondine. I'm part of the YWCA, and I would like to just recognize Dr. Camara Jones She's done tremendous work in working with the CDC in the past. She has a history of advocating and standing up for anti-racism works. And if you guys have any questions at the end, she would be willing and gratefully to address any issues or any questions that you guys have in terms of health equity, public health, and the disparities that we're facing right now. So with further ado, we will start. So we've seen that COVID-19 has been disproportionately killing Black African Americans at a very high disproportionate rate in terms of our white counterparts. And I think it's important to state that racism and not race has been a major issue in driving and increasing these health disparities that we're seeing right now. So my question to Ms. Dazon, what was the state of the paternal health equity in Atlanta prior to the pandemic? And how has the pandemic exacerbated these dynamics?
Greetings, Andine and Michele. Thank you so much for the invite from my what I call my sisters and my comrades and co-conspirators at the YWCA, domestic and global. I'm really grateful for this invitation and to be here this evening and for this conversation in the series of conversations that you all have been hosting starting today and going through the weekend. I'm really intrigued by a lot of the different conversations that are going on. And I don't want to say happy because it's not happy. The earth is angry with us, but beloved and a thoughtful Earth Day to you all. This is always an important moment to stop and take a minute to think about the fact that, and as I listened to someone the other day said that we're not here to save the planet, it's really saving the people who are killing the planet that we have to work on. And that starts, I think, with recognizing what's going on with Black women and with our health globally. And I say that because until we center so many of our critical issues with Blackness and with Black women, not only in an equitable or an equity standpoint, but just from a justice standpoint. And then for reality, I just finished a paper that I call the Sankofa paradox, for a Sankofa standpoint, meaning knowing our history and knowing where we've been and paying attention to the lessons from that so that we know which way to go forward. And if there's any lesson that we first must remember is that whether it was during the slave trade, whether it was during slavery itself, whether it was during and the time of and post-colonialism, and then post-slavery and Reconstruction and Jim Crow and the whole nine, is that never was there a time where people did not rely on the wisdom and on the nurturing and on the sheer talent of women of African descent to catch babies, to deliver babies, to have babies, to raise babies. And I think that we don't remember that. I think that we also don't remember, and I don't say this with any kind of apology, is that but for the existence and the body of an African woman, we would not know where our humanity began. And so if we start right there without, like I said, any apology, I look at what we talk about as equity now and say, I don't think there was a state of equity that we can define. There are numbers, there's different statistics around disparities and how horrific they are in terms of the Black women's experience, regardless of economics, regardless of income, regardless of educational attainment, regardless even to some degree of geography, with the exception of the fact that we cannot forget that we live in different economies of scale inside this country as well as in the world, is that we still have the highest rates of Black maternal mortality in this state, in Georgia, as well as this country, which I'm sure Darby's going to share a little bit more about from the work that she's done in her research. So the state of equity was pretty bad. It has been and still is a situation and a condition where we have, first and foremost, an inability to recognize that race medicine exists within obstetrical care. We have not yet wrapped our full public health heads around the fact that women's bodies matter and that Black women do know their bodies, and that we don't trust what Black women have to say about their bodies. And we're not listening to Black women because we don't value Black lives. And when I say we, I'm talking about the collective we, and you know that for true. So we have systems, for example, I work primarily in the around the issues of HIV and AIDS and the intersections of reproductive health, rights, and justice. And it wasn't so long ago that we learned by sort of default, when looking at how, if, when, and how we were rolling out the Affordable Care Act, which of course we still have not done and have yet to see, that we learned just as recently, even I think in the earlier parts of the 2010s, that in the state of Georgia, we also had the highest rate of perinatal HIV transmissions, right? We had, out of 11 birthing hospitals in the state, in just in the metropolitan Atlanta community, 10 of those birthing hospitals did not follow any of the perinatal prevention guidelines for women who are living with HIV. For example, not providing testing in the third trimester for syphilis was one of the core issues and causes of those perinatal transmissions. But aside from that, we also have situations where there are just not basic protocols that are being followed in our clinics, in our physicians' offices, as well as in the hospitals with regard to prenatal care, with regard to pre-delivery care, as well as with postpartum care. We also have the situation where prior to COVID, and not having the Affordable Care Act expanded, not having enough Medicaid coverage, and not having enough Medicaid expansion coverage, even for those who were eligible for Medicaid because of pregnancy, that we see that too as a structural issue and a structural barrier. The thing with COVID that I think we're not also recognizing enough is the role that violence has played, for example, not only in the lives of Black women, but in the detriment to Black women during pregnancy and during delivery and after delivery. And the fact that we know that violence increases, and where violence is present, it increases specifically for women and people who are pregnant. And oftentimes for people who are in violent situations, protecting themselves or preventing pregnancies that are unintended is also an even bigger challenge. So if we're in situations where the lockdown has created more vulnerabilities for us, then we've also seen those cases where violence has gone up. I want to bring in one more issue that I think, and there's so many, there's a long list, and I think there was a piece that Robert Wood Johnson put out not too long ago, just about how the pandemic has actually increased demand for more data. So because we just don't actually even know what the true impacts have been yet, because we're not collecting enough information on the health inequities and on where the accountability needs to lie. But I think that there's this other issue that we are having to address, which is the fact that a lot of the concerns about Black maternal health overall, and Fleda Mass Jackson probably started this work so long ago with her work on preterm deliveries, and the fact that it wasn't about economy, it wasn't about education, it wasn't about income, and it wasn't about poverty per se, but it really was about stress, and that the core elements of stress start with structural racism, and that structural racism, as Kamara teaches us so beautifully, is that structural racism then extends itself into individual racist practices, and then that extends itself, of course, into the biases within the clinical care settings and individual providers themselves. And as a result of that, I would think that it wasn't just the COVID crisis that has increased those racial disparities and inequities and the crises, but also the stresses around the police violence, the stresses around the increased violence during COVID lockdown periods, the increased stresses of losing work, And of course, for women who were working and then could not work during the COVID crisis and were not eligible or able to work predominantly because they were responsible for caregiving of their children or their elders and everything else that we have to take care of when we're not at home, as well as what we are at home, is that has increased concerns and worries. And I think that the stresses and the worries about contracting COVID-19 or the coronavirus has also increased our inequities. I'll close on this one, is that we have had a pregnancy that happened at the beginning. We actually had our delivery right at the beginning of the pandemic, and the changes that we witnessed as an organization, and we're intentional about how we were even more tuned in to what her needs were and how she was concerned about her delivery and her post-delivery experiences, was so vastly different and so vastly more intense than before. And being able to choose hospital delivery versus birthing center versus home delivery versus making sure that there is midwifery available, all of those kinds of things, even in the face of policies that don't support, especially where we know that midwives predominantly in our communities are Black and brown, and that they were not protected during COVID as essential health workers. All of that comes together in terms of mattering how healthy and how safe these deliveries have gone. We now have a young person who is born living with HIV and who is pregnant, and who prior to her pregnancy had also contracted coronavirus at some point earlier in the pandemic. Can you imagine all of the concerns that she is having now around vaccination, around non-vaccination, around how to manage her prenatal care in a space where she might actually be less or more vulnerable because of her HIV status, but maybe less vulnerable because she's already had COVID-19. So we got a whole host, a whole basket of intersections that we have yet to really tackle to understand the differences before and after COVID. But what I can say is that the heightened awareness around racial inequities and the structural racism has not done us any favors in terms of improving Black women's outcomes.
Thank you so much for that great answer. And thank you for addressing the multifactorial effects that do influence health disparities and the maltreatment of Black African American women and the maternal side. So Darby, my question to you is, based off of what we've heard Ms. Dazon just spoke about, how do the trends align with what we're seeing on a national level?
Yeah, and thank you, Dazon. It's interesting for me just to hear your experiences on the ground, since I spend my time as a researcher, hearing what folks are doing on the ground. And I do have some sort of the national stats that might be helpful to add in terms of the maternal health angle. So I think many on the line may know this, but the US has such a severe maternal health inequity crisis. Our maternal mortality ratio is increasing. It's actually increasing over time versus decreasing like most other industrialized nations. And we certainly have the highest mortality rate across all other industrialized nations, almost double the country, Canada, that comes after us. And to me, what's sometimes the most hard to see is that 60%, so almost 2/3 of the deaths that we see are preventable. So that's sort of, the maternal health angle that Dazon can speak to much more deeply than I can, but those trends certainly hold true when we look across pretty much every condition, every disease, every measure of health outcome that we can look to. We see similar disparities due to race. So to me, one of the most impactful data points I come across and that I communicate with the hospital and health system executives that we work with is the life expectancy gap. So in many cities, the life expectancy gap between Black and white residents is really significant. And in DC, it's 17 years. So if you're a Black man in DC versus a white man in DC, your life expectancy is 17 years apart. And for Black women versus white women, it's 12 years. So this has real tangible impacts on people's lives. And to Daison's point, this, some people say, okay, is it class? Is that what the problem is here? But it's, so although class is deeply intertwined with race, and socioeconomic status does impact your health, this is certainly directly related to racism. So how I typically talk about this with executives that I work with, so hospitals and health systems, I try to explain the 4 different ways in which racism can manifest in your health. So first, internally, that goes to some of the concept of weathering that Daison was talking about. So how does the stress and the impact of prejudice and discrimination, how does that actually impact the cells and the genes in your body and contribute to a lower life expectancy because of that intersectional impact of racism and sexism? So that's sort of the internal angle. In terms of interpersonal, that's when we get to, all right, what are the disparities that are occurring at the site of care? So are care teams providing all patients with high quality care, regardless of their identity, or are they letting biases and misinformation get in the way of how they treat patients? So that makes me think of a statistic I saw recently, which was almost half of like early first and second year med students believe the falsehood that Black people have thicker skin than white people. And what this means is that they sort of are underinflating the pain assessments that they're giving their patients, and they're undertreating the pain that their patients have. There's plenty more examples like that too. So that's internal, interpersonal. I also explain to folks that it's also an institutional thing. So this is about where the care is located. Do folks have access to primary care and like maternal health care and behavioral health care and all of those things in their communities? And is the care high quality? And then lastly, the sort of the biggest bucket is the structural bucket. So structurally, who has access to communities that are highly resourced and have the things that make you healthy, like the social determinants of health? Do folks have access to healthy and stable housing? Do they have access to food? Or are they living in food deserts? Those kinds of things that impact your health are very much structurally determined. And I appreciated Daison's discussion of the COVID-19 inequities. We've been tracking this pretty closely. And the most recent estimates I've seen is that Black patients, Indigenous patients, Latinx patients, they're more than 2 times as likely to die from COVID as white patients. So that's, we've been talking about these disparities for a year now. We've known about it for a year, but that's still the case. And there are a few reasons for it. So it's the disparities in terms of who had the pre-existing conditions pre-COVID that put you at risk of worse outcomes. We know that was a disparate outcome or disparate input, I guess. Secondly, inequities in the healthcare system itself. So who has access to vaccination sites that we're seeing pop up in our communities? Who is actually able to get to their appointments? And then lastly, the social determinants of health, which I think Michelle was alluding to at the beginning. So again, who is able to work from home and who is not, who is able to socially distance and who is not. And so in our research, we have identified, of all of the things I've just discussed, the reasons why we see what we see are directly tied to the 2 root causes, which are intergenerational poverty and structural racism.
Thank you, Darby, for mashing all those points together. And I think it's very interesting that you brought up the research about, or the myth about Black people having thicker skin. I think us just bringing awareness to this myth and fallacy and trying to just dismantle it is another initiative in how we can, close this gap. So next we will have Sloan ask questions. So Sloan.
All right. Well, yeah, thank you both for really laying out the groundwork for this discussion and giving us a good understanding of what, based on what both of you all have said, is a quite dire situation, and one that we have to address at both national and local levels. So my first question for you, Daison, is how does your organization specifically try to address these complex and structural inequities? And if you tell us how you're doing it in Atlanta and also nationally, that would be wonderful.
Oh, I think you're still muted.
I did. You know, it's not muted. It's not muted. I call it my selfie mic check. So, no, but thank you for the question, Sloan. And so Sister Love is a 32 plus, well, coming up on 32-year-old sexual and reproductive health rights and justice organization. And so the core, sort of the core element or the core component of our work is intersectionality, right? And another way that I look at it is that we address intersectionality at the margins. And a part of that means we're using intersectionality to pull the margins to the center. So a lot of the work that we do first and foremost is about centering Blackness, period. It just, everything starts there because we deeply believe that, given the fact that, the way I say it, that Black women are relegated to the bottom of almost all the barrels, that we believe that when you fix the problems for Black women, you fix the problems for everybody, because as we rise, so does everyone else. And that in and of itself speaks to what the inequity looks like. It is that stark. And I'm grateful to Darby for bringing up the data on life expectancy. So some of the things we do, of course, are obviously, one of the most important things for us is that we intersect service and advocacy. Right. So we're not a clinic, and we're not a OBGYN provider of services in that regard. We work with a whole lot of partners who are. We work with a lot of local clinics, and we also work to train and educate providers as well as our community on what some of the newest issues are, how these issues are all interconnected and intersecting, and how they're all related. The other thing that we do is we're all about making sure that we are honed in and lifting up, if not only lifting and listening, but also amplifying the stories, the lived experiences, what I also call Indigenous expertise, which I think is the data that is always missing when we're talking about doing studies and doing trials. And that the fact that women are experts of their own lives. And not only that, that I think it's important, we talk a whole lot more about the fact that when you're thinking about that Black, you know, not think, what was that thing about the Dr. Dorothy Roberts puts it in a little bit of a different way when we're talking about pain, but that, you know, a lot of trained medical practitioners just think that our bodies are different enough that we're supposed to hold pain that more. And I think what they're confusing and conflating, which is how Sister Love goes at the work, is what you are conflating fortitude and resilience, right, with biology, and whether that's mental or physical in terms of well-being and pain. It's a confusion that we have to continue to disrupt and dismantle. Just because we can survive all the crap and all of the horrendous things that have been put upon our lives and our bodies for centuries does not equate with the fact that we don't feel pain the same way others do. So that's the first thing, is to make sure that the women themselves recognize that their strength and that their capacity to survive does not necessarily mean that they feel anything, or that they are less likely to feel pain in ways that others are, and that their pain is real, and regardless of what that pain is. The other thing that we do, in addition to making sure that we're clearly educating everyone we see about these issues, but also starting to mobilize and help them understand how their stories are connected to the policies that impact their lives, and that the stories that they have are not necessarily the ones that people are making decisions based upon. And so when you hear folks like, and we lift her up all the time, Congresswoman Ayanna Pressley out of Massachusetts has said it the best in a lot of our reproductive justice spaces, when she says that the people who are closest to the pain must be the people who are closest to the power, means that Sister Love spends a lot more of its time creating spaces where the conversations, as members of Black Mamas Matter Alliance, for example, that we're a part of making sure that the spaces that are created are incorporating and including those women who have barely survived with their pregnancies and their deliveries, those family members who have lost women to the maternal years, and also that we've actually incorporated some of the stories of children, of those people who were born to mothers who passed away or who died as a result of childbirth. And in so including that, we're creating a different narrative of who should be in supporting or making or promoting the decisions. The other thing that we do that I want to be real clear about is that we are very much honed in on making sure that folks are getting access to the healthcare that they need. So that means we're continuing to fight for the expansion of the Affordable Care Act, that we are in total support of the moves that Black Mamas Matter and the Black Birth Alliance and the other organizations that have really promoted, for example, National Black Maternal Health Week that just took place last week in conjunction with, of course, this month on focusing on Black health and on International Maternal Wellness Day, that we are a part of making sure that the powers that be see the different ways of being able to raise the awareness that's needed. And of course, taking every chance we can get to call in and deal with providers that we learn about who are either out of ignorance or out of bias or out of sheer racism and racial indifference, are not practicing what needs to be practiced in terms of protecting women's well-being and outcomes. I want to say this too, that in a new initiative that we're working on, where there's a press release that'll be coming out in the next couple of days, University of Georgia has also been doing some intense studies on crisis, what people know of as crisis pregnancy centers. What we haven't been paying attention to, because most people focus in on the CPCs and we also call them fake clinics because that's what they are, that these are facilities that pretend or present themselves to be healthcare providing facilities when in fact, usually they're very deeply religious, Christian religious based facilities that are run predominantly by conservative folks that are strictly anti-abortion and are setting up these facilities to deter, not prevent abortion, because they would also be providing contraception if that was the case, but they don't. So deterring people from making choices to terminate their pregnancies. What a lot of people don't know is that they're also stretching into HIV and STI testing, but not providing appropriate referrals, not providing appropriate resources, and certainly not providing appropriate care for people who have positive results from that. So there's all of these ways for us to tackle fake clinics like that without even having to deal with the abortion question, because if we just went in on the Black maternal mortality question, then we need to collect a lot more data on the damage that they are doing to women in the 80,000 of them that exist across this country. And in this state, they've received over $9 million over the last 7 years or so to do the damage that they have been doing. And I would pose the question, how culpable are they in the role that they have also played in the increased disparities of Black maternal mortality in the state of Georgia? So the work that we do is also use research to really promote and push advocacy at the state level, as well as within our metropolitan community.
Wow, thank you for that. Just very incredible answer. I mean, clearly there's so much work to be doing. And one of the things that I just heard in that answer is how important in terms of doing the service and the advocacy is the education part of it, is making sure that because the work is so interdisciplinary and interconnected, that when there's miseducation in regards to certain services, that it affects services over here as well. And that actually brings me to, would love to bring Dr. Jones into this conversation, who in her role previously as the president of the American Public Health Association, I'm sure could really speak to, what is speak more to about this ideal of needing increased advocacy and education to address these inequities. So, like, Dr. Jones, if you're ready, you can hop in.
So
okay, there
I'm
we go.
here. I
Thank
wasn't
you for being
expecting
here.
to speak. I was expecting to learn. So I appreciate this opportunity. The only thing I would throw in is I am becoming more and more concerned about racism denial as a black hole in our nation. It has huge mass, but you can't see it, but it's sucking things into it. And racism denial is so staunchly held in our nation and so seductive that even people who put out statements last summer, for example, or people who maybe marched or put something on their Facebook, they might start forgetting why they said the things they said. And clearly naming racism is an important first step. My work is on naming, measuring, and addressing the impacts of racism on the health and well-being of the nation. And naming racism is essential because if you don't name a thing, you can never address that thing or dismantle that thing. But if you name racism without moving to action, then it's lost. Naming racism is essential, necessary, but insufficient. So in my work, I do a lot of storytelling, honestly, allegories on race and racism. And there, I've come to recognize the 4 key messages that we need to communicate. The first is that racism exists. And a lot of people would even argue that point, right? But it does. So, you know, I have my little dual reality restaurant saga allegory with this open close sign, but many people are addressing that in their work or in their data collection or, you know, whatever. The second of the 4 key messages is that racism is a system, because often people who are resistant to talking about racism resist because they think when you say the word racism, you're trying to divide the room into who's racist and who's not, or you're trying to peer deeply into their soul to figure out exactly how racist are they. So when we understand we're dealing with a system which manifests through individual actions, as both Dazan and Darby have talked about, but in its essence it's a system, then that changes the conversation. We're all adversely impacted by the system. The third is that message that racism saps the strength of the whole society through the waste of human resources, also in how it's divided us one from another and divided some people from their own interest. The fourth of those key messages is that we can act to dismantle racism. So we don't have to give up. We don't have to throw up our hands, oh, it's too much. Sometimes if we don't understand the power of collective action, it can seem overwhelming. But collective action can protect us, it can propel us, it can inspire us, it can, you know, sustain us. And so that's the importance of collective action. So when I was APHA, American Public Health Association president in 2016, I launched our association way back then on a national campaign against racism with 3 tasks: name racism, then ask how is racism operating here, and then organize and strategize to act. And I think that those are still the 3 tasks that we need to be engaged in. I will say that indirectly, our national campaign against racism at APHA inspired the work by Lillian Payne and others in the Wisconsin Public Health Association, who passed a declaration declaring racism as a public health crisis, which was then adopted by Milwaukee County in May of 2019, and then the city of Milwaukee and so forth and so on. The last time I looked, which I honestly was at the beginning of March, there were 183 jurisdictions, cities or counties, or at that time 8 at the state level, but 183 jurisdictions across 33 states that had made some kind of declaration that racism is a public health crisis. And it has grown and it is growing. And as I said, that's important. But what happens after the declaration? What are the partnerships that are going to be? What are the investments? What are the bringing new people to decision-making tables, going into community and investing in the work that's already going on where people are trying to solve their real problems? So naming racism important, and then next, what?
Yes. And I know you have a next question, Sloan, but I just want to throw in, because Darby put a really important message in the chat when she says, and now the CDC. And I know that, Doc, you ain't going to say it, But even way before the time when there were those of us who in very heavily mobilized to make sure that you were elected into that position as the president of APHA during that time, because that was Dazon speaking now. That was personally my payback for those days when you were censored before your racism research and for your work on structural racism in public health when you were at the CDC. A lot of folks don't remember those days, but I do. And I remember how painful that was for all of us and how much that hurt. And not only that, but how I think that that actually set the CDC itself in a different light and in a different place for those of us who thought that we could rely on the CDC to put all of its efforts to ending the racial disparities that were affecting us, especially in HIV, in sexually transmitted infections, and in reproductive health. And so big ups to all of the work that you have done in vindication of those days. So I'm really, really excited to be able to just say this publicly and to have it recorded and have other people see it later, because I think that that's an important thing to say thank you to for being that champion for us.
Thank you, Dazon. And thank you for all of your work. Yeah.
Oh, and I gotta say, Dr. Jones, I'm so happy that I asked you that question, because I mean, I would have thought that you were fully prepared, because that was an amazing answer and really has just like wrapped up like everything that Darby and Dazon have been saying. And so thank you. And we're gonna go to the next question, and we're just gonna kind of like keep moving through. And this is gonna be a question I'm gonna pose actually to all of you all that have been answering questions for us. Is in your, like, from your perspective, what can people who are motivated to advance health equity due to what we've been talking about this evening, what can they do within their communities and in their workplaces? And we have some questions that people talking about, what can I do at work? What can I do with my friends and family? We'd love to hear your thoughts on that.
I'm just going to jump in because I think that this week is like a perfect time to bring this together and talk about what it looks like. So it shouldn't be a shocker when you have someone like a Serena Williams who comes way public and can connect the fact that the challenges that she had with her pregnancy and with her delivery were deeply connected to her Blackness, because she had all the resources, she had all the best care, but somehow that did not matter. And so now it is public and it is well known and it is documented, and people have had a chance to see and understand through the same kinds of social media that people were able to see what happens behind the cameras between the police and Blacks, quote, so-called suspects, and how we are being killed and how we are being erased and negated. And what I think people need to do the same way, and I think it should be, if it has to be, as I'm an old act upper, right? So if it has to be as extreme as taking to the streets on behalf of Black women's lives, on behalf of Black mothers and Black bodies that give birth lives, then we also have to recognize what it means when communities come together. What we recognize when those police incidences happen, when those violent moments happen, whole communities come to the street, whole communities move to make sure that that person's life is lifted as someone who mattered. For people who are Black or brown and pregnant, communities must also come together the same way to rally around that pregnant person as a community, not leaving it up to her, not only leaving it up to her family, but recognizing that her health and her well-being, to have a healthy delivery and to stay here to raise that family that she intends to raise, that is as much a community active part of the revolution as taking to the streets to dismantle police brutality and the racism that exists within our criminal justice system. We should also be taking to the streets to dismantle that same racism that exists within our public health system. You can do that in the workplace, because that's what people have been able to do. You can do it in your social media spaces. You can do it in your social groups and networks and in your activities. You can do it on the road. You can do it anywhere where we have been able to call out Black Lives Matter. It's important to call out pregnant Black Lives Matter as well. And that, I think, is most important, is that we see it as a community and we attack it as a community.
Well, it's hard to follow that. So I'm not in the same vein. So we're going to say ashe and leave that right there. But I just wanted to lift up that I have 3 principles that I think can guide any organization or group or community or person who thinks they're wanting to be about health equity. And those are: 1, valuing all individuals and populations equally; 2, recognizing and rectifying historical injustices; and 3, providing resources according to need. And although those are kind of lofty principles, let me just help us start operationalizing each of those. But really, in whatever your setting is, you can then take my examples of operationalizing and operationalize it there. So how do we know if we're valuing all individuals and populations equally? Well, the clue I give you there is think about how you might value your children or your nieces or your nephews, you know, like anybody like that. So you would protect, you would invest in, you would celebrate, you would surround with resources, you know, all of those things. We, among us right now, could come up with 30 valuing verbs in a minute, right? That's how you value all individuals and populations equally. Think about how you value your children or those children around you. The second thing, recognizing and rectifying historical injustices starts with understanding the history of your location, of your company or, you know, community, the history of your city, of your state, of this nation. So one of the 7 barriers that I've identified for achieving health equity, or one of the 7 values targets for anti-racism action, or one of the 7 social delusions that undergird the intergenerational transmission of racism denial. I have called it all different kinds of things. But one of those is the fact that we as a nation are ahistorical. We act as if the present were disconnected from the past, and as if the current distribution of advantage and disadvantage were just a happenstance. So learn local histories, and as well as more regional and whatever histories, and then we have to be willing to rectify those historical injustices. So however that computes for you. The third one, providing resources according to need. That's equity 101, right? Like, people have now really started to understand that equality is not equity. But in that providing resources according to need, there are 2 steps. The first step is establish a metric of need upon which we all agree. So maybe it's maternal mortality rates. Maybe it's infant mortality rates. Maybe it's COVID death rates or COVID infection rates, or maybe it's, you know, whatever, per pupil spending in schools, whatever the metric of need is. So establish a metric of need, and we can say, oh yeah, this is a metric of need. That's step 1 of 2. The second step is, when you get some resources, have the political spine to distribute those resources according to need. Because lots of people can say, oh yeah, this is a good metric of need. But when it comes down to it, and they get some resources, and then the politically well-positioned say, but we need some too, then they lose that understanding of need. And they tend to sometimes just give equally, sometimes give more to those who need less. And those demands, well, we need too, from community A, when in fact community A is doing so much better, results from the fact that community A doesn't ever compare itself to community E that really needs more. They don't even go across town. They don't even know what it looks like. And any of us, all of us, usually compare ourselves to those who have more. So they might say, well, we need, because they're comparing themselves to the billionaires without understanding the real need. So anyway, I'll be quiet again.
Yep.
Thank you all for just sharing that wonderful information, especially the fact that addressing stories and speaking out on our experiences is how we just drive policies and understand who needs what and where it needs to go to what. And so currently I will open the floor out to questions. We have about less than 10 minutes. So anyone who has questions that would like to be addressed to the panel, you guys can unmute your mic or drop it in the chat at this time.
Hi, my name's Maggie. I put this question in the chat, but I work for the American College of Cardiology, and one of the things that we are really focused on right now is diversifying the healthcare workforce. And I was just curious to your thoughts on that and the impact on that and where you see that taking us in the future.
This is something that actually Michelet is truly spends day in and day out talking about. So Michelet, I wanted just to bump it to you in case you had a thought. I know you're not a panelist, but this is truly your expertise.
I think, well, Maggie, part of your question was about the impact of that, and I can't say that I have numbers on that piece, so I will ask some of the other panelists for their input on it. But I mean, there's a lot of data out there that shows when you have diverse teams that they are more innovative, they are better at making decisions. But I would say what's important in that is that you also have to have inclusive work environments, and I think most organizations aren't there yet either. So even though I think Dr. Jones called this out too, and Dazon as well, people have been making statements, and I think people, at the top of the organization are saying these things, but then the people that work within health systems may not feel that their day-to-day experience has actually changed. And so I think there's also a value in understanding, how do we create an environment where people of color, where Black people actually want to work in the healthcare system. So that would be probably one of the things. Like, you have to work on the pipeline too, because people have to be trained for some of those jobs if we're talking about clinical roles and all of that. And are we investing in supporting people to do that, and not asking them to fund it themselves first and then reimbursing them, but paying for it and hiring them into roles where there is actually a career ladder. So we also see in healthcare that a lot of the roles that people of color might be in are on the lower paying jobs. And to me, that is not what equity or justice looks like, unless we're saying that we're going to help those people advance into roles where they can make even more of a living wage. So those would be some of my, I think, thoughts on that. I've also seen in talking to chief diversity officers and chief human resource officers that there has to be more accountability around what are our goals as it relates to representation in our workforce. And a lot of people are still hesitant to put numbers behind that, to put dollars behind that and incentivize executives on it. And I don't think that there will be movement without that, because the people who are hiring, we can say all day long that we care about this, but if I'm not incentivized in any way to do it, there are no repercussions for me hiring the same people, it's not going to happen.
Mm-hmm. May I throw a sort of a question or an idea out there, which is, what would it look like if we said, okay, we know that we don't have representation according to the population or according to the state or whatever at all levels. So let's just try to have representation at the top first. Like we're not trying to do pipeline. We're trying to do representation at the top, because the people at decision-making tables then influence agendas, they influence values and all of that. And it's been my observation that people at decision-making tables always think that they have everything they need at that decision-making table. And if they're going to bring somebody else in, well, it might make a nicer picture, or be more politically palatable, but they really don't expect that there's going to be any new information brought in. And that closed-mindedness and that self-satisfaction and that feeling that they know everything that needs to be known is harmful. So what if we had, I don't know how we would do it, but like you say, okay, well, we can't get, great representation throughout. So we're just going to start at the CEO and at the board, the CFO, and then we'll work our way down. I mean, we want representation, huh?
With the deciders.
Yes, with the deciders.
Mm-hmm. Yep. I keep thinking, if Keith Ellison wasn't the state's attorney general in Minnesota, would we be sitting here with Derek Chauvin going to prison right now? And so, or, lifting up the veil on so much of what's hidden behind the blue wall. But we have a dear friend here in the state of Georgia, Dr. Bonzo Reddick, who is just an incredible thinking clinician and medical provider and an educator. And I roll it back. We just had a session. Loretta Ross, one of my favorite people and my best friend, is currently teaching a course, Calling In the Calling Out Culture. She's been teaching this course, but the one that just started last night, and you're still eligible, you can go to her website, lorettajross.com, and sign up, because there's 3 more classes to go. But this one is a calling in the calling out culture for Black communities. So it's specific for Black folks to look at how calling out doesn't help us, especially when we're working with each other and as allies and as comrades. But there's something that Sonia Renee Taylor said last night in her talk that sort of shows up for me in Bonzo's stuff that he does around DEI in the healthcare field. And I'm the first person to talk about how diversity, equity, inclusion as a framework and as this whole new body of, I don't know what you want to call it, in the workplaces is failing. It's not hitting the mark by any measure. And for those, if anybody is on here, I saw someone in the chat, so this is no individual disrespect at all. And understanding where it comes from and what the efforts have been, it is not enough. And it is certainly not enough for where we are right now. And so we have to think differently, which for me starts with the human rights framework versus the DEI framework. And it also starts with centering all of what we do with people first, not with the system, not with the providers even, but with the persons who are presenting these challenges. And so there are these 4 things that Bonzo talks about that I think from a provider perspective makes a whole lot of sense and sort of breaks it down to something individually that I'm not calling it simple to do, but simple to say and understand. And the first is just to increase the awareness that you have about the people that you're serving. Get to know more about the disparities based on the specialty that you're working in or whatever public health approach that you're taking. So if we're talking Black maternal mortality, there shouldn't be a single obstetrician who does not know what those disparities are in terms of Black maternal mortality and morbidity, and to understand where those disparities come from and why they exist. And then to individuate how you respond to that in a given patient's life. So making a conscious effort to focus in on their story, on their specific information, what their experiences have been, and what traumas or what stresses or whatever conditions or healthcare needs that they have been experiencing in their own lives, not just in this large social category that we can stereotype people in, but what their individual thing is. So that's like not trying to walk in their shoes, but walking in their hearts and hands. That's a different thing. That's coming from Sonia Renee. And then take some perspective, right? Make some conscious effort to be surrounded by something different than you. By being in spaces where you're having to humble yourself, find that conscious and cultural humility to be in other spaces where listening and learning from how people do what they do and make the decisions they make and live the lives they live, how that works and how that happens so that you have different perspective on how to even hold that conversation with them. And I'm not trying to say get down with the language. That's not going to go over well either, but to really get down with connecting empathetically with the stories, with the feelings, with the emotions, with the experiences, and with the expressions. I think that those things are pretty basic, but they're not taught in medical training. They're not taught in public health training. They're not taught in most places because you would have to start with race and you would have to start with sex and with gender and with origin in order to get to those places. And people have to get past their own biases before they can even start there.
Thank you for addressing that. And that brings me to a question pertaining to the Black Maternal Health Mombas Act that recently passed in February. And so my question to you, Daisy, what are some initiatives that you think that that Sister Love is looking to see in terms of just this new policy?
So, well, I'm going to repeat what I said before. The first thing that we're looking for is the full expansion and implementation of the Affordable Care Act as just the first step to go from there, because that at least begins to kind of wage or build a wedge in these disparities, right? It's supposed to create a little bit more equity to quality healthcare. So that's the first thing I think. The other thing around this act means is that it's going to require different training And I think that community engagement has to be a part of that training. I believe that community engagement belongs to community, that it doesn't belong to the institutions, it doesn't belong to the researchers, it doesn't belong to the corporations, the health insurance providers. It belongs to the community, and the community should be resourced in order to make that engagement happen. And that engagement means that we have to have some of what this act is going to allow us to do is to create more accountability boards, to create more bodies of communities of people who have lived the experiences of the racial injustices that happen in maternal care and in maternal health, that we're also going to understand the role that trauma-informed care and that mental health play in maternal health is also an important component that I think is coming through with this act. And the fact that we now have at least for the moment, that we do have leaders, that we have more Black and brown folks who are sitting in, thanks to Georgia, that we even have a little bit of a teeny majority in some of these decision makers. You know, we flip big houses in the state of Georgia. And so that we now can see that we have, by understanding that our votes matter as well, that by having people in these positions that can champion our issues, that we can educate communities about who these people are and what they are doing. And then there's a whole lot more that we're going to be doing specifically as Sister Love, because we, as a part of Black Mamas Matter Alliance, we're going all in on making sure that we're educating people about what the act is actually providing for folks, and understanding how to individually advocate for these things on their own behalf when they show up with their providers. Knowing what your rights are is just the beginning of being able to fight for them. And so that's really a major part of it. But I think another piece that's really, really critical and important for us is that we're now able to use this piece to make sure that there are resources that are being allocated and also distributed. And one of the other things that we do all the time, and this act doesn't necessarily represent it yet, but it gives us the gateway or the door to get in, is that for people who don't know how HIV, for people who are not covered by their private health insurances, or who are at the lowest end of resources in terms of income and healthcare coverage, the one thing that from one particular part of the Ryan White Care legislation that is the largest funder of HIV/AIDS medical resources in this country, is that it is also the most democratized piece of legislation that impacts people at the local level. And what I mean by that is that those resources are made to communities that are hit hardest by HIV and AIDS, and those resources are determined locally. What the priorities are, where the money gets spent, how the money gets spent, and who gets the money to provide those services. And when we know that people, especially Black people, do better with our health outcomes, when our providers look like us and understand us and come from our communities, then our health outcomes, we do better with our health outcomes. That we should be able to use this Maternal Health Act to do some of the same stuff, not just the pipeline, but making sure that the people who are already in our communities and in our care are able to provide better care based on some of these principles and practices that have gone into the thinking of the act, but also into the thinking of the activism that's made it happen.
I mean, this has been an absolutely tremendous conversation. And I feel like I have so many takeaways from both of you of thinking about how do we put humans first here? How do we put people first here? And I will definitely be still in that line, Dr. Jones, about we don't have to pipeline work here. We can just put people at the front, and we can to take it back to what you said, Dazon, the beginning is we're looking at this maternal mortality rate, and we're looking at these healthcare inequities. If we put Black people, Black women at the forefront and put them centered, we will bring everyone together as a whole. We will uplift us all. So we're a little bit over time, but I want to just say thank you to our panelists. Thank you, Darby. Thank you, Dazon. Thank you, Dr. Jones, for just stepping in and answering so many questions. And Undine and Michelle, this has been great. And to our audience, it has been absolutely wonderful to be in discussion with you all. The YWCA is doing this all as a part of our Stand Against Racism Week. It's a great way to get involved and to learn more about these topics. If you are in the DC area, the second event that will be happening is this Saturday on April 24th from 12 p.m. to 2 p.m. Is the annual Stand Against Racism rally. It's at Freedom Plaza, and that is from 12 to 2. So we would love to have you all join us, and we would love to have you all continue to talk about these issues with us, talk, advocate, and educate. So thank you and have a wonderful evening.
Okay, I removed everyone.
That was so great. And I was so nervous. This is my first time like facilitating like anything.
Good job. It can be hard to like you think about what you're doing next and you're like, I'm chatting you and then they're saying stuff and like I'm trying to be present so I can hear what they're saying so I can put it all together and do more than just ask a question. You did a really nice job. They may have us do all of the courageous conversations now.
Uh-oh.
That was bomb.
Wait, hold on. I realized that we're still recording. So